I'm Frank Diamond, the managing editor of Infection Control Today. We're helping infection preventionists and others on the front lines of infection prevention and control as they guide the American healthcare system through the COVID-19 pandemic and look to the post-COVID world. With me today is Professor Hudson Garrett, who has an extensive background in healthcare, including infection prevention. Professor Garrett holds leadership positions in a slew of healthcare associations, including Pediatrics Subcommittee for SHEA, the Society for Healthcare Epidemiology of America, to name just one. Professor Garrett, thanks for joining us today.
Thank you very much.
We, society in general, and the healthcare system particularly, learned that infection prevention and control needs to be a constant and shouldn't be confined to just one area. What do you think infection control in hospitals will look like in the post-COVID future, which we hope will come sooner rather than later?
I mean, I really think it goes back to the CDC core practices for infection prevention and control, really looking at basic elements like hand hygiene, disinfection of the clinical environment of care, the correct use of personal protective equipment, and even having it available. These are some of the elements that we're going to more hardwire in our practices that really go back to basic practices that we should have always been doing. So in many ways, COVID-19 has been a fresh reminder of the importance of infection prevention and control, high reliability processes within our institutions, and quite frankly, also looking at the personnel factor, that human factors element of how people respond to these types of pandemic situations, both present as well as in the future.
When we touched base for this interview, you were actually on the job, right? You won't name at a hospital. What were you doing?
So for the last several months, I've been part of a specialty response team for COVID-19 patients, dealing primarily with taking them from one facility to another, or actually we've seen many of these patients unfortunately come from the long-term care facility. So it's been a very eye-opening experience for all of us that have been involved. We've seen some of the best and worst of healthcare, and unfortunately seen some of the most challenging circumstances that most healthcare providers have faced in their careers. So we have a long way to go, but it's been a privilege to be involved at the front lines of this pandemic.
What's the challenges in transporting people in a COVID situation, in a pandemic situation?
When we look back to things like Ebola, there was fairly clear-cut guidance. There's been some change and some differing opinions from WHO and CDC regarding transport. I know I'm having conversations ongoing with CDC colleagues now about sort of hardwiring the best practices to protect pre-hospital professionals as well as critical care transport. We've also seen a change in the last few weeks, especially with pediatric patients that are presenting with COVID-like illness, especially Kawasaki disease. So it's been an interesting challenge to really educate pre-hospital professionals as well as the emergency rooms with being prepared for these patients that might be walking through the front door with little or no notice.
Well, that's a hard thing to deal with, pediatric patients who have COVID. I mean, did that surprise you?
No, I mean, we've seen novel viruses that have affected pediatrics very differently than adults in the past. We've seen, of course, the eradication of things like polio, but we've seen these novel viruses have very interesting symptoms, like flaccid limbs where there's some temporary paralysis. With COVID-19 infection in pediatrics, they present with cold-like symptoms. And so this can be very problematic as we approach the fall and winter months where those traditional respiratory viruses will be very prevalent in society. So, testing and good diagnostic tools and hopefully a vaccine in the near future will be critically important as we prepare for sort of these next ebbs and flows of the virus.
You fully expect that there will be ebbs and flows, but will you go so far as to say that you're pretty certain there'll be a second wave?
I mean, I think this is going to become more of a seasonal-like illness, similar to influenza. And if you look at the data and the predictions from CDC, they very much support that. Whether or not we'll have multiple large waves, is yet to be determined. If you look at the national data, there's multiple states that have had an increase in the number of new cases. Of course, with current political situations going on and protest, there's most likely, going to be another wave of this that comes in. Again, we look at the age demographics, the personnel that are most likely to need healthcare services are those older patients, but that could change. So, just because a particular state or geography has an increase in new cases did not necessarily set off my red alarms. I really look at basic things like total number of new cases, hospitalizations, deaths, and most importantly, available healthcare resources to care for patients should there be another wave of this.
A lot of healthcare had to improvise on the run, face this pandemic. Do you think that anything good can come from out of that improvisation?
I think American innovation and ingenuity has a tremendous play in this conversation. When you look at, facilities that were worried about having to share ventilators between patients and some of the completely MacGyverish tools and techniques that were developed to accommodate for this, it's pretty much a testament to how resilient healthcare providers are and are committed to patient safety. That being said, you can only survive for so long at that level of heightened awareness. And so as we look at this moving forward, how do we prepare our healthcare system for hardwiring these good infection control practices in the future? We don't have good hand hygiene compliance nationally. We need to work better on the clinical environment of care, and we certainly have both supply chain and correct utilization challenges related to PPE. So these are all areas that I'm hopeful that healthcare leadership across the entire continuum of care, not just acute care hospitals, but most notably long-term care facilities, can really bring some more leverage to the table here. And public health has really emerged as that conduit between all of these different sources, which is great because our public health professionals fight an amazing fight every day, and in many cases get little recognition compared to what they need to. And so I think COVID-19 has been a great wake-up call to say, how do we all come together at the same kitchen table to solve the complex problem before us?
Do you think infection preventionists will have an expanded role in the healthcare system in the future because of this?
I mean, this has always been a part of an infection preventionist job description. Dealing with outbreaks and pandemics, it's pretty rare that in your career you deal with a pandemic. We deal with outbreaks every single day. So, this is really sort of heightened again our sense of awareness, and is probably exposed some areas where we have probably the biggest opportunity for improvement. And I don't ever look at anything as an obstacle. I look at it as an opportunity for how do we fix it? How do we hardwire it? How do we put together the resources? And, in many cases, resources are not FTEs. It's not cost. It may just be a process redesign. It may be having the right product at the right place. And it also could be just a simple infrastructure to support one another, because what we have not yet seen is the wave of PTSD-like illness that will most likely come from many healthcare workers that have been exposed to COVID for months at a time, wearing PPE for 12 to 16 hours sometimes a day. These are all things that we have to think about as unintended consequences of this pandemic.
What was one of your, I often ask people what their worst day on a job was, but what was one of your best days on a job? You have one, or is it just kind of, is it all blur at this point that you've been working so hard?
I think, yes, your days get blurry, but, when you see a patient walk out of a hospital, or when you take a patient back to a facility and they're still alive and they survived this as a result of interventions that you and the team provided, it really is a fulfilling day. What I worry about is making sure people don't drop their guard. We always want to have a heightened sense of awareness for infection prevention and control. We don't want to become germaphobes. I don't want to be wearing a mask for the rest of my life, but I do want to make good practical, and good common sense judgments and decisions. One of the most recent things that I've seen that has a little bit of concern for me is, as we restart elective surgeries in the outpatient setting, many ambulatory surgery centers are doing COVID testing, which is great. It's good to know if it's coming in your doors so that you can be prepared and refer those people to better care settings where they can care for that type of infection. But what concerns me is if you're having an elective surgery on Friday and you're being screened on Monday or Tuesday, that really doesn't have a lot of relevance to me as your healthcare provider, because I don't know if you're positive when you walk in the door on Friday. And so we need to, again, make good practical, decisions here that are rooted in evidence-based practice versus just doing actions to, make ourselves feel better. And I think that's a real difficult reality that we need to face, is using rapid diagnostics to their fullest capability.
And how contagious COVID is, that's one of the things that makes it so difficult to deal with in the first place, right?
Absolutely. I mean, it's a highly contagious virus, much more so than influenza. We also have, challenges with the PPE shortage. And even if you do have PPE, is it something that's going to be properly fit tested? And so sort of that respiratory transmission component of this, in addition to the hands, the mucosal membranes, and the surfaces, it really brings us a lot of awareness to how much our living environment around us can contribute to infection transmission.
You said earlier that what you're doing, infection preventionists are always there. They're always on the job, and what they're doing is basically what they've been trained to do. Um, but do you think their jobs will change as a result of COVID-19? For instance, do you think they'll have more responsibility in monitoring other departments? I'm thinking of environmental services or maybe food service.
Well, I mean, first of all, there's really no role in food as a source of transmission. So I think we should sort of take that off the table. Environmental services is a department that infection prevention and control already works with hand in hand. That clinical environment of care that's maintained by our EBS colleagues is a very big part of this equation. I don't necessarily see the infection preventionist role changing or evolving per se, because again, they've already been involved in this. And I draw our attention back to a couple other examples. We've had SARS, we've had MERS, we've had Ebola, we've had novel bird flu, and now we've got a novel coronavirus. This won't be the last. And so what have we changed in those past settings? And really the answer is not a lot. We had some localized preparedness. We certainly did some Ebola training, things like that. But as soon as it's, the current threat is out of the sort of, right in front of your car, on the road, it's very easy to forget these things. And so I think our biggest challenge is that overall resiliency, and to say, let's not prepare for Ebola, let's not prepare for SARS or coronavirus, let's prepare for that next pandemic infectious disease threat and ensure we have the proper people, process, and products in place to be able to combat that. And I think that's really where we need to spend our time and money.
But human nature being what it is, people do lapse, people do, your procedures kind of go by the wayside once the crisis situation is over. But do you think that this was such a calamitous, history-changing thing that this time some of the lessons will stick?
I hope so. I mean, certainly the financial and clinical operational issues for healthcare facilities, and I mean all healthcare facilities, have been enormous, unlike anything that I've ever seen in my career. I'm hopeful that especially CEOs at hospitals will use this as an opportunity to really beef up their infection control resources that they're providing to those colleagues. And frankly, some of the worst things that I've seen have been in our long-term care settings where, despite sometimes their best efforts, they simply can't contain this and it spreads like wildfire. I mean, I've been in nursing homes where 100% of the residents had it. And over 75% of the staff had it. And, these residents are not leaving the building. So that means that the sole source of transmission is the staff that are coming in and out and or potential vendors. And so we really got an opportunity to say, let's not take our foot off the pedal. Let's not lose that positive momentum, but let's ensure that we're hardwiring the things that we need to do all the time in order to protect the patient or resident.
Is that one concrete change you see coming that CDC might say to nursing homes, you need a full-time infection preventionist on staff?
CDC and CMS have always advocated for this. CMS recent guidance has said you need to have somebody in this role for sure. The ability to enforce that nationwide is difficult. There's a cost associated with that. And even if you had a warm body there, those individuals need to be properly trained. Long-term care is very, very different than the acute care environment. Having done a lot of work in that space, I can attest to some of the unique challenges that they have. And so, it's very similar to, pediatrics is not just small adults. Long-term care is not just small acute care. And so we really need to be focused in our efforts, ensure that they're reporting to the NHSN system within CDC, and that we're collaborating across the whole healthcare continuum of care with really public health as sort of that center conduit. As a resource for both data awareness, but also sort of transparency and best practice.
Did public health drop the ball during this crisis?
I think that's a generalized question. Did everybody drop the ball in some aspects? Absolutely. Every single player in this equation is imperfect. And so, if you look at CDC's response as a whole, I think there's a lot of things that they could have done better. But I still have the utmost confidence and consideration for colleagues at CDC. I think given the circumstances, they are pumping out guidance and information as quickly as they humanly can. Having looked back at Ebola and all the resources they put out there, this seems to be thousands of times more resources and man hours that have been placed into this. Granted, certainly the toll, not just clinically, but also financially on the country and frankly, the world has been tremendous. But I think public health is really good about self-evaluation. CDC, I think, will learn many lessons from this, but I'm very appreciative of the work that the men and women at CDC, as well as the U.S. Public Health Service and other government agencies have done to try to combat this and provide resources in their very limited resource environment.
As I mentioned earlier, you're on the job. You got to change out your scrubs for this interview. You'll probably change back into them after this interview is over. How many hours are you working today?
I've been working close to 30 to 40 hours clinically every week, in addition to my regular other responsibilities. So, we're not necessarily. I mean, we're seeing a little bit of a downward trend here in the Atlanta area, but we fully anticipate that this will be going on for a period of time. And, one of our biggest challenges is to prepare for the fall and winter seasons, where we sort of have that mix of our regular respiratory infections. And so the ability to have rapid diagnostic tools, a vaccine, hopefully in the future, and great proven therapeutic options are going to be really critical for our success as we move forward, not just with this, but as we look at preparing for future pandemics that might be related to this.
So that's how you're preparing for the fall. Make sure you have enough tests and maybe even change the processing system a little bit.
Well, our screening needs to change. We need to, I see many, not just healthcare institutions, but, consumer settings that are simply asking for temperature screening. And that's not going to capture all of these patients, especially those that are truly asymptomatic. And so, asking questions like, have you been exposed to someone with known or suspected corona patients? Have you been outside of your local community? 2 months ago, if you said you went to New York City and came back, I would have serious concerns. The data is much better. I really prefer the Johns Hopkins map that is available, sort of that heat map of looking at cases in a localized geography. But, if you think about Atlanta as a perfect example, we have, roughly 6 to 8 counties that make up our metro area. And so just because the county I live in is lower as far as new cases does not mean the metro area where I may be traveling or exposed to is down. And so, data can be very deceiving. And, I hope in the future that we'll really move forward in a proactive approach, make sure we have the appropriate PPE. And with PPE, I think we need to think about alternatives to these disposable solutions. So for myself, as an example, I don't wear an N95 respirator pretty much anymore, except if I'm popping in and out of a hospital. I'll typically always wear an elastomeric respirator that's reusable. Or I also have a PAPR as well. And so these are all solutions that help us be more sustainable, have better reliability and better safety for our healthcare team.
Any final words of advice for infection preventionists or environmental services or anybody that's working in hospital these days about that you've gained from your experience? Anything you can tell them?
I think the only important thing is to say thank you for the work that they do every single day, not just during this pandemic, but have always done. Thank you for the recognition that they bring to patient safety and the work that they do to protect patients and themselves. And we all need to stick together. If we've learned anything through this, is that when all the players come to the table together, we have such an amazing opportunity to not only, sort of stop these pandemics in their tracks, but we also have an opportunity to learn and collaborate. And it doesn't matter what credentials you have after your name. It really is about, do you have a sincere interest in advancing patient safety and reducing risk associated with healthcare associated infections? And if you answer yes to both of those questions, you're welcome to be on my team any day of the week. And it takes every discipline, every person, every resource, every healthcare leader from the top to the bottom, vertically and horizontally, to fight something like this.
Professor Hudson Garrett, thank you for stopping by and talking to Infection Control today, taking time from your very busy schedule to do so and share your knowledge.
My pleasure.